I'm Dr. Michael DeTola.
And I'm Megan Strong.
A dentist from Hawaii, one of our Glidewell Ohana, writes in and wants to know why denture teeth are so soft.
And Evita didn't want Argentina to cry for her, but you can definitely cry for this soccer player from Argentina.
And CAD/CAM technology has revolutionized the crown and bridge world. Today's case of the week, I'm going to show you how CAD/CAM is now available for the toothless. That and more on today's Chairside Live. Hello and welcome to Chairside Live, episode 70. If this was our 70th wedding anniversary,
yes,
this would be, I like that you'll go along with this premise for once, that we're married. This would be our platinum anniversary.
It would.
A famous dental material. We used to use it a lot here in the laboratory, but like gold, got very expensive, and it was part of the thing that pushed everybody to zirconia. But regardless, how are you this
I'm
week?
doing well. I'm doing really well. As I mentioned on the last previous episodes, I was cutting out sugar from my diet.
I remember.
I've been doing pretty well. Had a couple slip-ups, but it's progress, not perfection, and we're back on the saddle. And
what were they, big like slip-ups? Like I craved sugar so much as a kid because my dad was a dentist and we weren't allowed to have it. That I remember opening a box of Jell-O chocolate pudding and literally eating the powder with a spoon. And it is awesome. It is really good. It's a big clump of chocolate that slowly melts in your mouth and it's kind of hard and granular.
That doesn't sound good, actually.
Well, it's not now.
You take what you can get, right?
Exactly.
Yeah.
We weren't allowed to have any sweets. It was the only thing I could find in the pantry.
Right. Yeah, no, they haven't been, okay, fine, maybe the one slip-up was, I went to my friend's baby shower.
Right.
And at baby showers, there's usually cake and treats and, well, let's see, I had a brownie and a piece of cake.
Oh, well, it's not as bad as it could have been.
And then last night I had ice cream, so.
Did you guys play baby shower games, like whoever crosses their legs first loses and all those?
We played one baby shower game where it was actually the most entertaining one that I've played at a baby shower, but they basically give you one word about pregnancy, and then you have to guess which candy, like candy bar name or whatever, goes along with that.
Give me an example.
What was it? I'm trying to think of what. I don't even know if I could think of one off the top of my head. So you can now, I guess.
But like if I said one word, like fertilization, or would that not be one of the words?
No, I don't think they would choose fertilization, but that could work. And then you would have to pick a candy based off of that.
That's what I'm having a hard time with.
Right.
Is picking a candy that matches Good and Plenty? I don't know. I'm trying to think of something that would go along with fertilization, but I'm not sure I can come up with it. All right, well, we'll save that for later.
Okay.
When you at your baby shower, we'll play something really fun like that.
Don't take that wrong. That's going to be a long time from now.
Well, we've been married for 70 years, and it still hasn't happened, so it's probably not going to. We've got an interesting case of the week for you today. You know, Bruxer and Emax, these are both CAD/CAM materials that now account for almost 80% of the crowns that we make here in the laboratory. And so CAD/CAM technology has had this huge impact on crown and bridge materials and what we use for these types of indirect restorations. And surprisingly enough, CAD/CAM has now found its way into the removable prosthodontic field. And what I want to share with you today for the case of the week is a look at how CAD/CAM is now affecting dentures. We actually have digital dentures, and I want to show you how it makes our job as dentists a lot easier. Let's take a look at that now. I was walking through the removable department the other day and saw something that I thought would be of interest to you because it was of interest to me, and certainly we all know how CAD/CAM has had a great effect on the crown and bridge world, and we've now seen it make its first foray into the world of dentures. And this is pretty exciting stuff. I like, at the beginning when I heard that the denture department was playing around with CAD/CAM, I thought it was CAD/CAM for the sake of CAD/CAM, you know, because it might be a good marketing angle or something like that, but I've been very pleased with what we've seen since then, and it's definitely not that. It definitely makes some things a little easier on our end, but it also makes them more accurate, and it makes for a better patient experience, and you'll see why in just a minute. So the first part's the same. You take the master impressions on the patient, send them into us, and we pour up the models, and then we scan that. And then instead of sending anything back, there's no wax bite blocks or anything. This is actually what we're able to send back to you. And you're going to notice, as I go to take this off, you're going to notice something that you really haven't seen before, or I haven't seen before, taking off wax rims from models. And that is that you have to struggle just a little bit to get it off because, there we go, because of the intimate fit between this and the stone model. And that's because this is actually printed on a 3D printer, an object printer. And you can probably see that obviously this is just one shade of material, of resin actually, that has been printed up here. And unlike the things we used to make before with the base plates that had the wax rims on, this is extremely accurate. And you got a feel for that watching me kind of rip it off this model. Now the good news is when you try this into the patient's mouth, you're going to get that same type of fit. So you're going to know instantly, this early in the procedure, you're going to know at this point whether or not the impression and the scan and everything is good, because this will fit in a patient's mouth, and if it's a good impression, they will have difficulty taking this out because of the palatal seal. They will struggle to kind of get it out, and that's a good sign. That's what you want to see. If you put this in and it's flopping around, before we go any farther, you know that we probably need to take a new impression. Maybe we missed something back here in the post-am area, but we're going to need another impression because this is the fit that you're going to get from the final denture. And so after the very first appointment, you're going to be able to see that. Before, with the wax rims, they would kind of go in and out and flutter all over. Sometimes we'd have to put denture adhesive in, and that was kind of a mess too. You'll notice that if you remember, if you've used us for removable before, on our old bite rims, we would just put the 2 central incisors there. Well, we have the opportunity to do a little bit more with CAD/CAM, and so we're able to set the teeth into some pink wax here so that you can make adjustments if necessary. So now all the anterior teeth are available to be moved. They're kind of in the perfect arch form right now, but you try this into a patient's mouth, and if something needs to be longer or rotated or whatever, it's just simply a matter of heating up a wax spatula, softening the wax, and moving the teeth where you want to move them. Same thing with the lower anteriors. We didn't used to provide that at all. We would not have any teeth on the wax rim, but now we have the 6 anterior teeth in case you need to play with those, or if you want to show us something about increasing overjet or overbite, you can do it by moving these teeth around, and this fits pretty well, but it's a lower, so it's not going to fit like the upper does. But again, this is an accurate representation of what the final denture is going to be like, which is actually going to come to you on the next appointment. And so there's really just 2 appointments there. Well, you got to take the impressions first and send it to us, but you're going to get this back from us, and you can try these in, and again, these are going to fit the same as the denture, so you should not need any adhesive, maybe a little on the lower, just depending on how much of the ridge is left. And then you and the patient verify whether or not you like the position of the teeth, or you can change anything you need to change, and then you're going to send it back to us, and we're actually going to duplicate it at that point with some hydrocolloid. And so we duplicate it with some hydrocolloid. Actually, it's a little bit different. It would be in a flask. So we duplicate it with the hydrocolloid, and then we will set the teeth into the hydrocolloid, as you might imagine it, and then put the regular denture material into the flask, and what we end up with is an exact replication of what you had in the patient's mouth, except of course it is now in the typical pink acrylic that we are used to seeing and that patients are used to seeing. But it's got all the same contours. Everything's the same as the first resin base that was printed on the object printer, except everything's just a little bit cleaner, and the finish is smoother here than it is on this resin, which was not made to be worn intraorally for any kind of long periods of time. And so at the next appointment, you already know how that denture is going to fit because you had this in just a week or so ago, and so you know exactly how this is going to fit, and there should not be any surprises when you get the denture and put it in, because that was definitely one of the things before where you had to cross your fingers a little bit. But as I mentioned, you'll learn very early on whether or not you have the fit that you want or not. Now, of course, these will get scanned as well, and so this will be kept in the patient's digital file, so there's always a record of this. The models were scanned, so certainly this would be a good time to make a spare denture perhaps. Even if the patient lost or broke the denture, if it was in a reasonable amount of time, this same actual scan might fit really well. But even if it didn't, let's say it's been 4 years and they lose it, this is going to make a fantastic custom tray for you, or we could even print this for you, process it, and send this to you for a patient who's lost or broken a denture. And then you would simply reline this chairside and then send it back to us for the permanent reline, or you could put a soft reline material in there, have them wear it for a week and mold it, something like Viscogel, and then send it into the laboratory. So we could actually use this as kind of custom tray, if you will, but it's the same denture they had before, the identical denture to what they had before, but obviously we've probably had some ridge resorption over 4 or 5 years, and so they would just be able to reline this and then you would send it in to us. And so we'll always have that digital file hanging around in case you need it for something that gets broken. So in case you're wondering where we actually get the setup that's going to go into the teeth, it's from a library, and you and the patient are able to choose this. This is actually something that I'm holding on to a production version of it right now because there is over 60, I think it's 65 now, smile arrangements that are available. So you and the patient, and it looks a little bit different in the final brochure, the ovoid ideal, tapering ideal, ovoid feminine, square tapering, the things that we used to do in dental school, where we put the thing over the patient's face to try to get the shape of their face and then the shape of their teeth. So this actually shows a library of different smiles, some more masculine with flattened incisal edges, crossbite if the patient was a class 3 and doesn't want their friends to notice that they're still not a class 3, that can certainly be done. And then, of course, some more feminine looks where we've got more rounded line angles and kind of softer incisal edges. So you and the patient can actually kind of decide this together. There's a lingualized occlusion if you feel that's appropriate. And so when you get this back, it's going to be set up according to whatever smile you and the patient kind of decided on. And so that's how the arrangement is made. It's the digital libraries, the 65 different digital libraries that's going to determine how these teeth are going to be arranged. And so again, in here we've only got probably right now 9 or 10 of these that are actually printed up because the permanent books of these, the official ones, are still in production. But you and the patient can take a look at it together and decide, and that's going to determine what the setup of the teeth looks like on the CAD-CAM Tri-end dentures. Again, the bottom line is we've seen CAD-CAM really change our laboratory in terms of fixed prosthodontics. And now for the first time, we're really seeing it being used in removable prosthodontics, in this case for a full upper and lower denture. And again, the advantage is being able to see how the denture is going to fit at that first appointment, what you get back from us when you get this, and the ability to move 12 teeth around if need be. It's probably going to be these 6 anteriors, if anything, that gets moved around. And if the patient likes everything and you like how it fits, your next appointment, you've got a set of finished dentists. So CAD-CAM has made it into the world of removable prosthodontics, and the fee for this is the same as the fee for our regular dentures. So there's no additional charge to do the CAD-CAM dentures or to keep any of these files on store for you in case the patient needs them later.
Now let's go to a segment we call
Viewer Mail.
This week's viewer mail comes to us from Dr. Todd Okazaki from Hawaii, and he says, "Aloha, Mike. I see you're going to be a speaker at the Hawaii Dental Association annual meeting. What a treat. If you would like, I'd be happy to be your tour guide for a day. Also, I have a couple questions for you. Number 1, I'm working on a bridge from number 8 to 12 with numbers 10 and 11 as pontics. What material would you recommend? Then number 2, with denture teeth opposing natural teeth, I've noticed that as the denture teeth wear, the natural teeth super erupt. This ends up creating a clearance problem as time goes on. Any suggestions? Why don't they make the denture teeth harder? As always, thanks for the input."
Well, Todd, mahalo nui loa for your letter. Appreciate that. Tour guide for a day, that actually sounds fun. We'll see what my travel plans do. Maybe we'll tack on a day at the beginning or the end, and I'll get a chance to see your fine island. Spend a lot of time on Kauai, but not a lot of time on Oahu. So I'd look forward to getting to see some of the sites. Never even been to the USS Arizona, for example. So thanks for the letter and your 2 questions. The first one was about a bridge from 8 to 12 with 10 and 11 as the pontics, if I recall correctly. And you asked what material to use. Well, in my mind, there's really only 2 choices for something like that. It's either going to be a PFM bridge or it's going to be a full contour zirconia Bruxer bridge. I'm a little concerned about having the pontics on 10 and 11 and then just having that last distal abutment on number 12. Hopefully 12's a pretty strong tooth there, although those, first bicuspids are a little iffy. But the alternative is double abutting it on that end, and I'm not a big fan of double abutted bridges either because I've seen those fail plenty of times too. So you are a little bit stuck there, and I'm sure this is a patient who you mentioned implants to and they don't want it. So I guess going with number 12 is the better way to do it. In the anterior, bruxer bridges like that actually work very well because we don't have a problem with our rule of 27. You might recall we've talked before about how the connector between an abutment and a ponic on a bruxer bridge needs to be 27 square millimeters, hence the rule of 27. That's the height squared by the width. So essentially it needs to be a 3 millimeter by 3 millimeter connector between the two to have adequate strength. That's in the posterior where we really see that challenged most of the time. In the anterior, we usually have plenty of room to do that. The other choice would be a PFM bridge, but that's getting to the size where when we bake the porcelain onto the metal in the oven, and then especially as it cools down, it sets up tensile stresses because the ceramic material and the metal cool at different rates. And we've all had those large PFM bridges where all of a sudden the porcelain pops off, say, tooth number 4, and it's just gone. And the patient says, I wasn't chewing anything, and we know it's because of those forces, those tensile stresses that have built up inside of that bridge. So for that reason, for an anterior bridge like that, my choice for one of my patients would in fact be the bruxer bridge. And sometimes it's a challenge getting, say, a single unit anterior bruxer crown to match, like if we were doing tooth number 8 trying to match 9. That's always challenging, but here 8 and 9 are both bruxer and then coming all the way around to that first bite. So that would be my choice. If Emax was strong enough, that'd be a great option too, but it's not, can't handle that kind of span of a bridge or 2 ponics in a row like that. So given the choice between PFM and bruxer, I'm going to go with bruxer in that situation. And yesterday at lunch, I happened to be sitting next to the general manager of the PFM department, whose department also makes bruxer. And I asked him, and he's somebody who spent the last 20 years making PFM bridges and crowns, and he said I would go with the bruxer as well. I would not do a PFM there. So my money's firmly on bruxer. And your second question was about denture teeth and why aren't they harder? Well, there are some harder ones. You know, there's porcelain denture teeth. I checked back with our director of operations to see how many we did, and we literally did less than 25 last year. And for a lab our size, that's pretty amazing. Of course, the knock on porcelain denture teeth are they will wear the natural teeth opposing them. Your concern was the opposite, natural teeth wearing through denture teeth and getting super eruption of those natural teeth. And really the one that I'm going to recommend is from Dentsply. It's the Portrait IPN tooth. And this is actually a cross-linked composite tooth. And so it's got great wear resistance compared to, say, standard acrylic teeth. And I think you're going to find with those Portrait IPN teeth that you get a lot more use out of those. And they wear a lot more like a resin would, whether it's a resin onlay on an opposing tooth than the acrylic where the natural teeth seem to chew right through it. So the Portrait IPN tooth is going to be a good selection for that. As far as I know, that tooth offers the best wear resistance against natural teeth without going to a ceramic tooth that's actually going to wear the opposing natural tooth. And I'm pretty sure that you don't want to do that. So thank you, Todd. Appreciate the question. I'd love to give you some chocolate-covered macadamia nuts, but maybe when I come down and spend the oh, look at Megan in the middle of her sugar crisis.
I know.
Don't those
do
are
this
so
to me.
good.
Gosh, are they so good? And they've got the ones with like caramel. Oh, don't get me started.
It's the greatest of all nuts. You know, those are put together, though, here in California. When you look on the box, I think a lot of them are done in California.
Don't ruin it for me, okay?
The nuts are from Hawaii. So thank you, Todd. Appreciate that. Yes. And what do we have for him as our letter of the week?
Because he's from Hawaii, how about this photo?
Wow, that's okay. That's kind of a little bit of a stretch.
And, well, we also have another prize for him. If you would do the honor of grabbing that for me. Oh. All right, there we go.
That was not easy.
Nope.
All right.
How about a Chairside Live gym bag?
Wow, it's a beach bag.
Woo!
Or a gym bag.
Right, but I think it'd be great for the beach too because, I mean, hello, Hawaii.
Right, exactly.
You could, there's a lot of room in here. You could put a lot of chocolate-covered macadamia nuts, and your towel, sunscreen, sunglasses.
A few papaya, a mango, star fruit, local knowledge. Look at me.
Wow.
I remember one time we bought a bunch of star fruit at a store in Hawaii, and we were eating it, and somebody, one of the locals that we knew there, said, "Where'd you get that?" And we said, "We bought it at the store." And he goes, "You got ripped off. There's fields of them over here for free."
Wow.
And we felt like the pathetic howlies that we were.
Bless your heart. But yeah, we're going to sign this photo and send it on over to Todd.
I might hand deliver it to him in January.
Oh, rub it
no,
in.
I'll bring him something else in January.
Okay, okay, fine, that's cool. And then bring me back some chocolate-covered macadamia nuts.
I will do that. And why don't you give us some news while I sign that?
Hey, listen, sounds good. Here you are.
Thank you.
A former New Jersey dentist will serve 3 years in prison after admitting to dispensing painkillers in exchange for sexual favors. Prosecutors say the 62-year-old man wrote prescriptions for Percocet for undercover officers who came to his office on multiple occasions. He did not perform any medical exams or check for any symptoms before prescribing the drug. The man was arrested at a hotel after allegedly setting up a meeting with the officers. He must serve at least 9 months of his sentence before he is up for parole. And, of course, he has surrendered his license to practice.
Oh, that's a horrible story.
I mean, seriously? And the prosecutors were saying that it's even more deplorable worse than a street-level drug dealer, because he has medical training to know how absolutely addictive these narcotics are. And then in exchange for just as basically prostitution, it makes me sick.
Well, I'm pretty sure these street-level drug dealers know how addictive they are, too. That's why they're not selling bananas, for example. But, yeah, that's just, you're right. I mean, it's weird and it sounds crass, but it would have been, had he just paid for sexual favors.
Right.
I think it would have been, I think he still have his dental license. I'm guessing. Mm-hmm. I don't think that's a felony. I think that's a misdemeanor. Right. It's got to be, you have to have a felony to lose your dental license, and I think that would have just been a misdemeanor and would have been, although it's legal some places, he could have gone to Nevada, for example, or other places. So that's tragic to hear it happen that way. And I don't know if the people who he was trading it with for the sexual favors were the ones who were addicted, or if they were passing it on to someone else too, but that's amazing. And it sounds like, and this obviously I really don't know what I'm talking about, but it sounds like he doesn't have an addiction to the opiates themselves, but maybe to sex.
Right.
Because it seems like that is, you have to cross a big line and realize that you could get in a lot of trouble for doing something like that.
And be willing to risk it all. Yeah, he said that he's claiming that mental illness and sexual addiction are behind his actions, and he says that he's getting help for it, which, I mean, clearly, hopefully he is.
I did not know that part of the story. I take back what I said about not knowing what I was talking about. Apparently, I know what I'm talking about.
You know what you're talking about.
Well, that about wraps it up for this week's edition of Chairside Live. On behalf of myself, Megan, the production crew here at CSL, and everybody at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. A former nude...
A former nude.
Which is so horrible considering the nature of this story. Okay, ready.
I'm Dr. Michael Latola.
And I'm Megan Strong.
A dentist...
I just said that weird. Start over. Okay, ready. Take your breath. Thank you for that, Dr. D. Now let's go to a segment we call Viewer Mail. Did you do it too?
Yeah, he did. Yeah, I didn't do it. I didn't do it. He just did it.
I can see it in my peripheral.
I didn't do it.
These people.
Oh.
All right. There we go.
That was not easy.
Nope.